Dr. Praveen Chandra, who is a very accomplished interventional cardiologist and chairman at the Medanta Center in Gurgaon. He's going to be talking about changing landscape of percutaneous valve interventions. So he would aortic valve interventions. And I believe he's one of the highest volume TAVI operator in the country, and it will be very, we are very grateful for him to take some time out and be with us. Dr. Praveen Chandra.
So good morning, everybody, and thank you, Dr. Khanna, for giving me this opportunity to present some, new information, not so new, on TAVI now, because it is an evolving field as of now, and lot of cases are being done in India and everywhere else in the world. So today I'm going to share with you some interesting aspects of TAVI. Dr. Ivo has already given us a fantastic overview of where TAVI is today, where we have reached, and what are the things which are evolving at this point in time. So now I'm taking you to another aspect of TAVI, which is TAVI in difficult access, which means non-transfemoral access. But let me tell you first that these are the 5 valves which are now available in India. And these valves are, now commercially available for all of us. And in fact, in this, we also have now the Abbott Portico valve, which is available, which is a self-expanding valve. So these valves have been used, quite extensively from the transfemoral route. And earlier it was a transapical also, but I believe everybody knows that transapical is almost given up. And this is the type of valve which we are using today from the transfemoral approach on a regular basis. But sometimes we get very different kind of cases. And in here you can see that this is a typical patient who would, who has a very small valve area of 0.4, 82 years old, definitely a case of critical aortic stenosis at the age of 82 years is a candidate for TAVR procedure. But when we do the CT angiogram of this patient, we find that the peripheral arteries are not good. They are less than 5 millimeters at various places. And also it's having significant amount of calcification in the entire length of both the left and the right femoral artery. So which means it is difficult to go from the femoral access, and the chance of having a complication, which is a vascular complication, as Dr. Ivo told us, is very high in these kind of cases. Now, another case, another fragile lady, 86 years old, and has severe aortic stenosis and has preserved ejection fraction. Everything looks okay for the case to be done. But when we look at, we select the size of the valve, we select everything. But when we look at the peripheral arteries, we find that it is very seriously diseased, and the descending aorta has come to a size of 3.5 to 4, which means, and you can see the calcification, it's like complete blooming of the descending aorta, and the lumen is less than 4 square millimeters, which is very, very small. So in this kind of cases, we cannot go from the transfemoral approach. Then of course, more cases we will see that this is a young lady who has severe skeletal deformities, rejected by the surgical department and for the SAVR procedure, and is now being considered for a TAVI procedure. So when we looked at the CT, everything was fine. We thought that it will be okay. Even if it is a bicuspid valve, we will be able to do it. But we checked, the coronary heights were low. We also checked the arteries. The access was again very, very small. They were in the range of 3.5 to 4 millimeters, both on the right and the left side. So what do we do? So we have to know what are the different kind of accesses which we can do in these patients. Although we know that 90% of cases are being performed from percutaneous femoral access, sometimes it is an open femoral access, but in about 10% cases now, we have to go for alternate access. And in our series of nearly 400 patients now, we have done about maybe 15 to 20 alternate access. And as you can see, that these are all kind of cases, valve in valve and also native valves. So why we are saying all this? Because access site complications are the most common complication of transfemoral TAVR and can lead to bleeding and even death in some patients. So this is very important. We have to identify these patients Who are these patients? Especially many times they are female patients with peripheral vascular disease, calcifications, and if the device size is going to be very high or sheath size is going to be big, these are the situations where we have to start looking at the alternate axis. And in here, this is one chart where how do we size the the device and the sheath. Here you can see that this is how we do it, depending upon the femoral artery size and the calcification in the femoral arteries. So why we are interested in this? Because the balloon expandable valves especially have a higher profile when they are entering inside the sheath, and the sheath is inside the vessel. So we have to have the sheath expand to the vessel size, otherwise the device will not go. And this happens many times with the balloon expandable devices, which are the MyVal and also the Edwards, both are available in India. So in these cases, like I showed, what are the probable sites from where we can go? So we can go from the transcaval approach, which is going from the IVC into the aorta, the transsubclavian approach, or a transcarotid approach. So these are the very feasible approaches. I'll show you some cases. So the first case I showed you, in this case, when we look at the CT scan, we saw that the subclavian artery is reasonably okay, and there is no major calcification, there is no major bend, and it will be a straight path going into the aortic valve. And here you can see that we have done an open access. The surgical team exposes the artery, and then they can put a sheath inside, and through which we perform the procedure through the same sheath which we do from the femoral side, although the part of the sheath will remain outside. So we position the sheath well, cross the valve, and then we are taking the valve inside, as you can see, which is going quite easily without any hassles. We position the valve, and once the valve is in position, we are checking it through the pigtail, and if everything is okay, we implant the valve, which is in this case it is a 26 millimeter balloon expandable valve. And once the procedure is over, you see that the valve is in good position, there is no significant leak or anything. Then we take the the sheath out, and the surgeons can actually immediately give us stitch, and of course the procedure is done. So typically the procedure is not lengthy, it takes little time to just expose, otherwise everything is similar. The second is, in this case, we found that the subclavian artery is also bad apart from the femoral. So we are looking at the carotid now. And if you look at the carotid, this is the subclavian, which is very diseased at the insertion site. So we look at the carotid, and in here you see that the carotid is the best vessel, goes straight inside the aorta through this carotid. And this is how we do it. It is open access, again, done by our surgical colleagues, the vascular surgeons or the cardiac surgeons, whoever is available. And it is, since the carotid is a very superficial artery, we can go very quickly inside. And this is done with the anesthesia, the MAC and the NIRS monitoring most of the times. And here you can see that once the artery is exposed, we go inside with the same, hardware, and the part of the sheath remains outside. We position the sheath so that it doesn't go too deep inside. And in here, in this case, even the other side was bad, so we had to do with a wire which is coming from the right radial approach. So here we had only two approaches, the radial and the carotid side. From carotid we took the valve, and from the radial we took the wire which is helping us position this valve. So you can see that this is a self-expanding valve here. So there is no limitation of either of these valves, you can use either of them. And here you can see that it is being positioned, and the position looks quite okay. And once this is done, then we also check on echo. If there is no leak, there is partially deployed valve, we are checking the echo. And if there is no leak and everything is okay, then we can leave the valve. If there is no gradient, it is absolutely fine to do that. And the carotid access, why we use it? Because it is very safe, fast surgical access. And carotid is being done for ages now by the vascular surgeons and the cardiac surgeons. So it is very easy for them to give us this access. So third approach is the transcaval approach, where we enter through the IVC, puncture aorta into the infrarenal part of the part, and put a sheath from IVC to the aorta. and then the TAVR is performed. Why we did this? Because in this case, all the approaches were wrong, bad. Like the transsubclavian was small, femorals were small, carotids were small. So here we took the IVC approach, and you can see this is the diagram showing that we puncture the IVC, go into the aorta, and through this we then position the sheath from the IVC into the aorta. And the fundamental pathophysiology here is that if there is a communication between the aorta and the IVC, the blood will flow from the aorta into the IVC and not into the peritoneum, because peritoneum has a higher pressure than IVC. So that is the advantage which we get when we do this approach. So planning is done by the CT again, and we find out the target site at the IVC, we find out the target site at the aorta, and then we do the puncture. And once the patient is on table, we do a simultaneous aortogram and the IVC gram, and then we go ahead and start the puncture. You can see that we have taken a right guide, and on this there is a microcatheter, and in this microcatheter we have the opposite end of the this wire, which is a 014 wire. So through this 014 wire we will puncture into the aorta and snare it, with the snare being put from the femoral artery into the aorta. And once the puncture is done, you will see that we are doing this puncture, which is held by electrocautery, which is just for a second. If you give it, it just pierces the IVC, goes into the aorta. And in here you can see that the wire will quickly go inside. We are just putting the electrocautery on, and here you will see that this wire will very smoothly penetrate into the aortic wall. And once it is into the aortic wall, then we are able to catch it with the this snare. So once that is done, you can see that we are already through the IVC into the aorta. This is the most important step. And once it is held inside the aorta, we can push the whole thing up, and on this we can guide the entire system, which is 18 French sheath can go from the IVC into the aorta. So here you can see that we are going up into the aorta, pulling the whole thing up from IVC to the aorta. So that is how it is done. And once that is all is in position, you can see that we are checking it again. It's okay. And we will put the sheath through this heavy duty wire on the IVC to the aorta. This is the sheath coming in. You can see that. And once the sheath is in position, we cross the valve, and here it is a balloon expandable valve, which we are using. And we are also using a coronary protection in this patient, because as I told you that the coronary height was low. So here we position the valve, do some gentle pre-dilatation, and then place the valve here very well. And you can see that we are checking at the ostium of the coronary, and here you see that there is some narrowing at this point. So we decided to put the stent also in the left main, ostium of the left main, so that the flow remains nice and good. So once everything was in position, we stented it, and after this we are checking there is no leak at all, and we'll take out the whole system now. And here you can see that we are now positioning a occlusion device. This is a ADO occluder which we are using, but while we were pulling it out, it actually jumped inside the IVC. So we already had this stent graft inside the aorta as a precautionary measure, which we immediately deployed. You will see that we will deploy it. Here we are deploying this covered stent, so that we seal this rent, and this rent is completely sealed off after this. And you can see that the covered stent is sealed off the leak, and there is no need to do anything further. The patient is doing very well after that. And so basically the all-cause mortality benefits of TAVI can now be even given to non-transfemoral approaches with these approaches now compared to the transapical approach. So transfemoral is a gold standard, but in many patients now we have to prepare ourselves for carotid and subclavian approach, which is easy and less invasive than the transapical approach. CT scan assessment is vital in selecting the right access. Switch before it is too late. So planning should be done much earlier. And transcaval access is also a very viable alternative with good results. And of course, to do all this, we need a good heart team with the vascular, surgical, and anesthesia support. So thank you very much, and I'm sure we can have some questions at the end of the session or whenever. Thank you very much.
Thank you very much, Dr. Praveen. That was perfect and very good. Now we'll go to two nightmare sessions. Doing TAVI is good and sometimes easy as it looks, but many a times we end up with real nightmares. The nightmares could be much more if you have not planned the therapy properly, have not done a pre-assessment properly. And but even if you have done it, I'm going to have two master operators in TAVI sharing their experiences with nightmares in the cath lab.